Welcome everybody to Global Response to COVID-19. This webinar number 12. This meeting is supported and sponsored by the Panamerican Trauma Society, the American Association for Surgical Trauma International Relations Committee, the World Coalition for Trauma Care, University of Miami, and Virginia Commonwealth University, VCU. I would like to invite Dr. Felipe Vega, President of the Panamerican Trauma Society, to introduce the panelists and the presenters, please.
Thank you. It's an honor to be part of this webinars. The presenters today is Dr. Esteban Foianini. He is a treasurer from the Panamerican Trauma Society and is also a director of ATLS in Bolivia. It's a surgeon and general director at the Foianini Hospital in Santa Cruz de la Sierra in Bolivia. Dr. William Sanchez, who is a professor of surgery at Nueva Granada Military Hospital in the university, is head of surgery at Central Military Hospital and president of the Colombian chapter of the American College of Surgeons in Bogotá, Colombia. And Dr. Pablo Ottolino is a general and trauma surgeon, chair of Media Relations of the Panamerican Trauma Society and founder of the Trauma Emergency Unit of the Dr. Sotero del Rio Hospital in Santiago, Chile. All of them are extraordinary surgeons that we're going to present today. Our panelists are Dr. Raul Coimbra, it's executive director of the World Coalition of Trauma Care, surgeon-in-chief at Riverside University Health System Medical Center, and professor of surgery at Loma Linda University School of Medicine in California and USA. Dr. Juan Carlos Salamea is a professor of surgery and trauma acute care surgeon in Rio Cuenca University Hospital, University of Azuay in Ecuador. Dr. Jorge Neira is the president of the Fundación Trauma in Argentina. Is a consultant of ICU in Sanatorio de la Trinidad in Palermo, president and Certification Council for Medical Specialties and former president Panamerican Trauma Society in Buenos Aires, Argentina. Dr. Bruno Pereira, professor of surgery at the University of Basuras, is the director of the General Surgery Residency Program at Holy House Hospital and treasurer of the Brazilian Trauma Society based in Campinas, Brazil. Dr. Ricardo Lima, professor of surgery at Federal University of State of Rio de Janeiro, at head of ICU at Samaritano Hospital, Rio, Brazil. Dr. Ruben Peralta, professor, senior consultant, and the director of the HMC Trauma and Critical Care Fellowship Program at Hamad General Hospital in Qatar. And Dr. Thomas Calea is our executive director, professor of surgery at the University of Maryland School of Medicine and physician-in-chief of the Adams Coley Shock Trauma Center in Maryland, US. Our moderator is Dr. Antonio Martos, Director of Global eHealth Trauma at University of Miami Miller School of Medicine in Florida, US. Dr. Esteban Foianini will present the first part of this talk. Dr. Foianini, welcome.
Yeah, before that, Dr. Vega, I would like to ask Dr. Raul Coimbra to welcome all the trauma societies and the surgical societies around the globe that join our conference.
Thank you, Antonio. As I say very often in this teleconference, this is a tremendous effort combining the Pan American, the World Coalition for Trauma Care, and the AAST, under which a number of global societies are represented. And once again, I thank you and VCU for sponsoring, particularly University of Miami for hosting. Welcome everyone this morning.
Thank you, Dr. Coimbra. We started this meeting 3 months ago, this webinar, and we thought that at this point this would be over. But unfortunately, this time, South America, Latin America has been hit very hard with COVID-19, despite of the time for preparation, etc. So we're going to have 2 presenters today talking about what's happened in their countries, and I have multiple panelists that are from Latin America discussing the situation. I hope you can can all help each other and to find some answers and answer some questions on how to improve the response in Latin America. So Dr. Vega, please can you call the first presenter? Thank you very much, everybody.
Yes, Dr. Foianini, please welcome to the panel and to share your screen. Thank you.
Very good. Thank you very much for the invitation. I'm truly honored, and it's great to be amongst so many friends and esteemed colleagues in this panel. I'm going to try to talk a little bit about the situation in Bolivia, and particularly Santa Cruz, Bolivia, which is where I live, which is the epicenter of the COVID disease in Bolivia this time. Let's see. Okay. There we go. So I just want to highlight this very quickly, and Dr. Marcos mentioned this. The trend now in the red zones tend to be more in the in North America and in South America at this time, and we are starting to feel more the burden of disease. This comes from the a publication that's given by the American College, which is compiled by General Electric, and you can see that the new cases in red represent Central and South America. The disease is starting to wane or decrease in the North American continent, clearly dropping down in Europe, and very stable over a period of time in most of Asia. And what is truly concerning is the data for death or mortality, which continues to skyrocket in Central and South America. So I'm going to concentrate mostly in South America and definitely on Bolivia, but I just want to highlight, if we look at our neighbors, Peru, Chile, and Brazil are in worse situation than Bolivia based on population. So the most active cases are currently in Chile, almost 3,000 cases per million, while Bolivia has roughly 745. In Argentina, Paraguay, and Uruguay, who are close neighbors, otherwise not directly a neighbor, but close enough, are doing a much better role with the containment of this disease. The other thing to highlight is if you look at active cases across the world, Brazil and Mexico are the two first nations right now. And if you look at reported mortality, Mexico, unfortunately, is at the top of the list. So one of the things that creates a problem for providing care in our region is the lack of hospital beds. If you look at Argentina, it has the highest level of hospital beds per 1,000 people in the region, above 3.8. I believe it's roughly 5. In Bolivia, it's a little less than 1. It's the lowest out of all the South American countries, and that has many reasons for that occurring, and it clearly impacts on this disease. Now, when we look at expenditure, and Felipe presented this last week, you can see that Cuba and Chile are at the top of the list. Roughly in Europe, the expenditure per person is about $3,500 within the European Union. In Bolivia, it's only $462. And then when you look at coverage in the different countries, Bolivia again is at the lower part of the list. And what this reflects also on the side, you can see about 25% of the hospital bill is covered by an individual, even in the public hospitals. Since our citizens are provided physician fees and the hospital bills, but a lot of the medications or other things are not provided and the patient has to pay out of pocket, adding to the burden. Also, Bolivia historically has had a very low number of intensive care physicians. There are only 190 as per this report in the entire country, and only 430 ICU beds. And one of the major problems is that most of the beds are not in the public sector, which is where the majority of the population receives care, but they're actually in the private sector. So I've extrapolated some numbers here, and you have to be careful because the image to the left of the screen talks about beds per 100,000 population in the United States. Based on this, these statistics has 34 beds per 100,000. The column to the right is per 10,000. So therefore, based on this data from 2006, Argentina would have roughly 29 beds, very similar to Germany and United States. There were no numbers here in Bolivia, but if I extrapolate it from the data that we have from the newspaper article, it's roughly 3. So the United States has about 10 times the number of ICU beds than Bolivia has at this time. Now, contrary to common belief, Bolivia is not an Andean country. Actually, the majority of the country is part of the Amazon basin. We border Brazil, Paraguay to the south, Argentina to the south, and then Chile and Peru to the west. And Andean region represents about 30% of the country. Historically, the majority of the population was in La Paz, being the capital of the country. But over the last 30 years, there's been a massive migration into Santa Cruz, which is where I live. And you can see in the census for 2012, it's roughly the same numbers. And we divide our country by departamentos or states. But currently, the numbers for Santa Cruz represent about 3.5 million in the departamento, and the city is close to 2 million inhabitants. And to put in consideration, back in 1975, there was about 250,000 inhabitants in Santa Cruz. So we've had a tremendous growth. And the bottom line shows the change in demographics in Bolivia, that now people are moving out of the rural areas into the city, and that's created a lot of burden because we have not been able to improve our infrastructure. This is just a quick timeline. And basically, the first case we saw in Bolivia was March 10th. I think this is important because what's been shown is that there's been failures of countries to close down very quickly when they've noticed the beginning of the spread of the disease. The first case, one was in Oruro, the other one in Santa Cruz. A lot of people suspect that the disease started in Santa Cruz earlier than that. And Santa Cruz is the largest city in Bolivia, has the international airport, is the most expensive and affluent city in Bolivia, with a lot of international businesses, and people tend to travel extensively from this area. 4 days later, the president actually prohibited people from coming in from China, South Korea, Italy, and Spain. And then they went ahead and closed down the borders, not allowing any type of foreign travel. And at first, there was a limited containment or curfew. And at this time, there's actually a very strict curfew. You can only go out from Monday to Friday based on your national ID card. You can only go out one day. Used to be from 8 o'clock in the morning till noon. Now it's from 7 to 12, or sorry, 2 o'clock. In some parts of the country, they started relaxing it because they have low numbers of COVID patients, but in Santa Cruz, which is where I live, they continue to be very strict. Although people are not complying currently with a quarantine, and I will discuss that a little bit further. So what we're seeing over the last 15 days, this goes to June 1st, a dramatic increase. And if you really look at the numbers from May 20th, or 21st, I'm sorry, to the date, we've gone from roughly 5,000 cases to about 10,000 cases. Furthermore, if you look at this graphic, this green line here represents Santa Cruz, which is where I live. And there's just been a dramatic increase. You can see that the rest of the country is pretty much plateauing. And the other area that's been affected significantly is Beni, which is to the north of the country, which is also part of the Amazon basin. So this is a report from yesterday, and you can see that about 70% of patients are actually in Santa Cruz. About 20% are in Beni, and actually pretty much scattered through La Paz, Cochabamba, which is the valleys, Oruro and Potosí, which are also part of the Andean region. They have a small number of cases. Now, there is some belief in the literature, and this is an image actually from Peru. This is from the Washington Post, but the Miami Herald, Boston Globe, and then there's been some YouTube videos talking about this, that there's low incidence of this disease in the Andean region. When they showed Peru, they had a similar situation in that country. And this is based on this report, which came out, I believe, a month ago. And what they allude to here is that when you're above 3,000 meters above sea level, based on the dry weather and also the fact of UV lights, that there seems to be a lower incidence of COVID infections. And this is looking at demographic information from Ecuador, from Bolivia, and also from Tibet. There's only one study. I don't know if this has to do more with just demographics, you know, low population, not a lot of foreign visitors, et cetera, et cetera. So again, this is a study that was presented by a mathematician here in Bolivia. And the important thing here is you can see the dramatic increase, but this line here is basically what we feel is ICU beds for the entire country. And the red line underneath that indicates occupancy. The problem is that the numbers of ICU beds are for the entire country. And the crisis right now is in Santa Cruz. So we are actually, we've surpassed our capacity at this time. You can see that mortality is increasing in the country, which is the bar graph. And this line here is just the mortality rate. At the beginning, it was roughly between 7 and 8%. Now they're saying it's about 3%. Although I feel that there are some patients that are not being reported. There are stories of people arriving at hospitals not receiving treatment and basically dying in the street. This is a communication from the state government of Santa Cruz. This is from May 28th. I just wanted to highlight what it says here is that the system is currently saturated. Personnel and equipment is insufficient, especially in the ICU, which is at over 100% capacity. And that in the last 11 days, they've seen an increase of 4,000 cases, which represents about 61% of the total cases since the epidemic started. So I'm referring back here to one of the best Westerns ever made, The Good, the Bad, and the Ugly. So what are the good things that have happened in Bolivia? I can talk about my institution. We quickly recognized that there was a problem. Fortunately, we have a strong ID team. We started looking at the literature. We created COVID teams, and we're a small institution, 80 beds. We're private, but we're considered tertiary care. Our ICU was 8 beds. We then augmented it to 11, then to 14. We had to purchase equipment, which was a real problem. But the main hindrance has been getting physicians and especially nurses, which are in very high demand. And there has been a significant number of healthcare providers who've become sick, just compounding the issues that we're having. We've also converted wards to COVID beds. So currently, out of our 80 beds, we have about 45 COVID patients. I'm very proud of my team. They've done a tremendous work in the ICU. We've had a very large number of patients come off the vent and go home or continue recovering in the hospital. And we're looking at our mortality. It's about the range, about 20% for people who are intubated in the ICU. And we continue to have, at this stage, we have 14 patients in our ICU right now. We're completely full. Locally, the state government, they decided to augment the ICU capacity by building domes outside of the many of the hospital structures. The problem is that they're not finished yet and they're not fully functional. They did purchase equipment and to support these units. We've had some issues with that though in Bolivia. And they keep on hiring nurses and physicians to treat the COVID patients. And that has caused a little bit of an issue with increasing difficulty of obtaining nurses. And also there's been an increase of salary of nurses, which has added to the cost of providing to these patients, care for these patients. Nationally, they did well with the early quarantine, declared a national emergency, and also created some stimulus packages for industry, cut off all payment of loans, and saw some type of stimulus packages to provide for people in the lower, middle, and lower classes within Bolivia, which unfortunately represent the majority of the population. The thing to highlight here is that people do not have access to a bank account and do not have credit cards. So there's no way to make a direct deposit. This has led to long lines at the banks. The bad. Unfortunately, most private and even public hospitals are unwilling to treat COVID patients. We have a 3-tier system here. Cajas represents people who are formal employees, about 30% of the population. 60 to 70% are in the public sector and a very small minority within the private sector. Local insurance companies have curtailed and are only covering about $2,000 for COVID coverage. That covers you for a couple of days in a private hospital on the ward and doesn't cover you basically for the first day in the ICU. So that's caused a lot of anxiety. Physicians locally have started prescribing ivermectin without any clear evidence and actually quite damaging. And also some physicians have started providing prophylaxis packages. We have a patient who just came out of the unit, got extubated, and he had been taking Bactrim and azithromycin beforehand. I was just reported this morning, he's got significant diarrhea, and we suspected it might be from C. diff. So clearly there's a damage to providing medication, which is unnecessary. There's been a local dentist who's been going around and treating local population, saying that this is caused by pneumocystis carinii pneumonia. And I highlight this because there's just all these things coming out in social media and people are self-medicating at home. Like I said, the lack of ICU physicians and nurses. Our rural areas are getting hit hardest due to lack of infrastructure. And the reality is for people of lower socioeconomic classes, it's just impossible self-quarantine at home. Sometimes you have entire families living in a room. We've had lack of PPEs with N95s. They started bringing in KN95s. Some of dubious qualities, a lot of them counterfeit. There's been price gouging of medical supplies. Just to highlight, surgical masks went from about $3.50 US for a box of 50 to over $40. We can't get RT-PCR results in a timely fashion. It takes usually between 4 to 7 days, depending if it's a private lab, which would be 4 days, or the public is 7 to 10 days actually. They brought in a bunch of antibody tests, which again, dubious quality, a lot of false positives, false negatives, and not really useful and actually creating more of a problem. And the population is unwilling to respect the quarantine. And I would say that the affluent people, out of ignorance, and unfortunately the majority of people who are the poor in my country, it's just because out of need. They can't stay home, they live day to day, they have no way to stay at home and respect the quarantines. These are some images you can see. This is recent pictures in some of the neighborhoods. Streets used to be empty about a month ago when I drive down to the hospital. Now there's traffic on all streets. You can see vans are opening up, selling medical supplies at incredible prices. Here we have the Minister of Health saying we should take ivermectin, and then the dentist who's been going around between Santa Cruz and Beni providing the different cares. The real ugly, like I said, majority of Bolivians live day to day. We have real problems with corruption. Private citizens and have been purchasing ventilators early when reports came that vents were what was needed. Hearing Governor Cuomo in New York, stories out of Italy. So when the hospitals went to buy the vents, they were actually all sold out because people have hoarded them in their homes, not understanding that the problem is not the vent, it's the physicians, it's the nurses, it's the infrastructure. We can't procure any medical supplies from the United States or Europe. Both have closed down. Trump was very vocal about that. The European Union didn't say anything, but you can't buy anything from them at this time. Unfortunately, demagoguery by political factions. Bolivia has a failure in the last 50 years to prioritize public investment toward public healthcare systems, lack of coordination between public, private, social healthcare systems or cajas, and the political squabbling making COVID a political issue instead of focusing on solving the medical crisis. And clearly, lack of leadership at the local and national level to curtail or handle this disease. This is a really embarrassing thing. They brought 170 ventilators produced in Barcelona. These are off the model from MIT. These are AMBU bags that are connected to a computer that was developed by Siemens. These cost roughly $6,600 in Barcelona. When they arrived in Bolivia, despite coming on the national airline and not paying, I presume not paying taxes, they were sold for $30,000 to the government. This has led to the Minister of Health that previously had talked about ivermectin being thrown in jail, and current investigation, I think there's 20 or 30 people who are being investigated on this. And this is the other reality. Many physicians, out of this group of 400, about a third are physicians and the rest are police and military who are actually working on the quarantine. They were very present at the beginning of the quarantine. Now I just drive freely throughout the city, never getting questioned. And I presume it's because most of the military and police are not willing to go out of the streets out of fear of being contaminated. So these are my personal views, and this is how I feel about this. I think this is a medical condition, and worldwide the medical community has responded to the best of their abilities. But it became a pandemic due to failure of governments and international organizations that should have served as watchdogs and failed to control the outbreak. And it's become a catastrophe in certain countries due to a clear lack of leadership, social inequities, and a lack of universal access to care. And I want to say I want to condemn the politicians, and I call them scoundrels, who look to profit from this catastrophe. But at the same time, I'm very proud of the international scientific and medical community that has come together for the common good. And I'm very proud to belong to the society and honored to share this with you. This is a picture that was taken a couple of days ago in my house. You see a toucan. I've lived in that house for 12 years. We hadn't seen them before. And it's just, things are changing. Wildlife is coming back. And this is a quote from an Austrian poet. It's actually from the end of Jojo Rabbit. And I take this to mean that there's hope. These are tough times. They're difficult times. It's difficult to see my colleagues sick in the ICU on the tube, but all this will change. All this will get better and the human race will prevail. Thank you for your time.
Thank you, Dr. Foianini. Great presentation, Dr. Felipe Vega. Please, everybody try to keep the time. What's your time for the presentation? Dr. Vega?
Yes, our next presenter is Dr. William Sanchez, that I already introduced. Please, Dr. Sanchez, go ahead with your presentation.
Thank you, Dr. Vega. Good morning, everybody. I would like to thank to Dr. Martos and Dr. Vega for the invitation to present the official data in Colombia. And I appreciate very much the invitation and honored to belong to this very important and elegant table with my friends around the world. Okay. I am a member of the government table with the management of the COVID disease here in Colombia because we are consulting with the military hospital and the Colombian Surgical Society. And I would like to present the official data about the Colombia government. I'm not sure it's good information, but really is a data for today. For today, we have more than 30,000 patients here in Colombia, with deaths near to 1,000 patients. Our first patient in Colombia was in March 6. If you can see it in the screen, March 6. For today, we have 30,000 patients for today. And the portion of the lethality is 3.2%, and the portion of the positive tests is near to 10%. What about the patient status for today? If you can see the map, the capital cities and the principal states in Colombia are with the most positive patients: Bogotá, Cartagena, Barranquilla, Medellin, and Cali. And we have two special zones with the border in the Amazons, near to the border with Brazil, in Leticia City, who have the most higher incidence in our country, and Bogotá too. If you can see, this is a slide, the portion of the patient hospitalization near to 10%, 7% in the general hospitalization, and only 1.5% in ICU. And the mortality is 3.2% of the patient. But if you can see, is inactive disease 60%, with a recuperation 35% of the patient. What about the age distribution? The majority of the positive patients are between 20s and 40s. It's very young population in Colombia. But by the other hand, the mortality are between 16 and 18, similar around the world is the similar. And what about the incidence? If you can see the graphic, Dr. Foianini made explanation previously. Colombia have near to 400 cases per million inhabitants. is a very low incidence around the world and in the Americas, as you can see. What about the mortality? The mortality at this moment for today is 3.2%, near to 1,000 patients. As you can see, the imagine in Colombia, we are very concerned because the trend of the mortality curve is very ascending. Is a very high preoccupation for today in our country. And the mortality per million inhabitants, we have 18 per million inhabitants. Yes, of course, it's low if compared with other countries, but we have a very preoccupation with ascending curve. What about the morbidities, the associated morbidities and the relationship with the mortalities? It is similar with all patients around the world. Patients with hypertension, with diabetes, with respiratory disease have the major association with the mortality because the mortality are between 70 and 80 years. This very elegant and useful tool with the government, with the National Health Institute, is about the evaluation day by day, hour by hour, the number of the ICU beds and the general beds. And if you can see, for example, with the available beds in our countries in near to 30,000 beds, for ICU, 6,000 beds. But in Bogotá, specifically in Bogotá have near to 1,000 beds for critical care. At this moment, for yesterday, the occupation is near to 47%. It's a very concerning because we are in the limit, the critical care beds for the patient attention. Of course, the total of the critical care beds, only 15% is for currently is for patients with COVID disease. The Colombian government made a model of the transmission, the curve of the transmission, as you can see, with the evaluation with the RT number. By April, with the predictive model, by April 24, the calculation was 24,000 cases. But you can see in May have a number minor than the April case. At the moment we are here with the curve. It's an excellent curve, but of course we are in ascending way because the patient per million of inhabitants is 4. What about the personal health with COVID disease? We had near to 1,000 patients, 4.3% of the personnel of the health are active with the disease. As you can see, the death is 11, asymptomatic 9%, and recuperation near to 70%. In the Colombian Surgery Association, we organize a national campaign to provide PPE elements to all surgeons and residents of Colombia. This campaign has been very successful. Our residents are protected. As you can see, Colombia have near to 400 residents for surgery. We have positive only 7 residents. And today we have only 1 surgeon for that. It's a very nice number with the promotion and the protective campaign around the country with support of the Colombian Surgical Society and the Colombian government. What about the hypothesis for the good behavior of the pandemic in Colombia? I think that the Colombia start very early with the strict quarantena. We started quarantena in March 20. By the other hand, a strict control of the national government in coordination with the local governments to make the strict laws about the quarantena. And the most important is that the government accept the recommendation from scientific association, in particular from the Infection Disease Association and the Colombian Surgical Society Association. We are working in very nice network with the associations, scientific association, and the government. By the other hand, other hypothesis is young and healthy population. The average year in Colombia is 22 years. 56% is minor than 26 years. 100% of the population has health insurance. This is very important because all the people have a medical service. And the other hypothesis is the TBC and triple viral vaccination near to 100% of the population. Other people say in a joke ideas the indigenous and ancestral blood protection. Other people say about the local liquor active protection, the aguardiente drinking. Other people say the Holy Virgin of Carmen protection action, you know. Other people say it was time that the Colombia get lucky something. This is the official data from Colombia government about the disease. Thank you so much. That's all, Antonio.
Thank you very much, Dr. Sanchez. Great presentation. And you see the difference, the great work was done in your country. Now I'm gonna go to Dr. Pablo Ottolini to comment about Chile, and then we're gonna have the discussion. Please, Dr. Ottolino.
Yes, hello everybody. It's for me, thank you for the opportunity to talk about the coronavirus pandemic in Chile. But I want to talk to Venezuela, but Chile right now is my second country. I want to apologize. I will dictate my presentation in Spanish. And so I will the need of official translator of the society is you, Esteban. This is his second job. And don't worry, my slides are very graphic and easy to understand. Well, bien. I want to talk what happened and what have we done. Es decir, qué ha pasado y qué hemos hecho nosotros ahora en Chile. Desde hace 61 días, para no hablar de tantos números, porque todos hemos hablado de números, desde el 1 de abril hasta el 1 de junio se han acumulado una diferencia de 3.000 a 100.000 casos. ¿Okay? Empezando con 293 casos nuevos, hasta tener hace 2 días 5.471 casos. Esto habla de 36 veces más la cantidad de pacientes, 3.500% más de pacientes que hemos tenido. Yo creo que esto se entiende muy fácil, Esteban, hasta este momento, ¿no?
Sí, así rapidito. Entonces, so what Dr. Ottolino is talking about, since April 1st to 1 June, you can see the numbers, it's increased 35 times over that period of time. Pablo.
Bien, este es el último reporte del primero, donde hay el panorama general de los casos, y quiero primero hacer énfasis en la mortalidad. Si tomamos los casos positivos, 59,000 casos, y las personas fallecidas, tenemos una tasa de mortalidad de 1.8%, muy por debajo de la que acaba de presentar William, de 3.2% de Colombia. Y si a su vez tomamos los casos realmente contagiados, no los casos que estén activos, que son mucho más, entonces la mortalidad probablemente baje al 1%, que es la que tenemos hoy en día.
So it's highlighting that their mortality rate is 1.8 based on all the active cases of 59,000, with 1,113 people who have died during this period. But if you take the total number of people who are infected, it's 105,000 people. So the mortality rate is roughly 1%.
Algo que es sumamente importante es la cantidad de estudios que se han hecho, y más adelante voy a conversar porque se han realizado hasta este momento más de 600,000 estudios o exámenes en pacientes, y actualmente en las últimas 24 horas, estoy hablando de hace 24 horas exactamente, habían 16,890 exámenes. Pero lo más importante es esto: el número de pacientes que hoy en día tenemos conectados a ventilación mecánica. 1,209 pacientes, críticamente 328, y obviamente con una disponibilidad de 286 ventiladores mecánicos según el Ministerio de Salud.
Okay, so what's been very important here has been the number of people who've been tested in the country, 600,000 since then, and I believe he said 16,000 in the last 24 hours. So there's been massive testing in Chile. And what's truly important here is the number of ICU beds. There's 1,200 people connected to mechanical ventilation, and they have 286 ventilators still available, and 328 people in critical state.
Bien, veamos los estudios que se han realizado, evidentemente la PCR, y vemos cómo es el comportamiento de la tasa de positivos en Chile. Y ahí vemos cómo existe un incremento, pero exponencial, que se ve a partir de al finalizar el mes de abril y el comienzo del mes de mayo. Fíjense cómo suben hasta llegar a una tasa diaria de 5,471 pacientes. Es decir, un aumento considerable del número de casos.
So the graph is just highlighting the number of people who are increasing to get to about 5,400 patients per day who are becoming PCR positive.
Si comparamos la cantidad de estudios entre positivos y negativos, vemos también el comportamiento de esa curva, como sin duda alguna la cantidad de resultados positivos va incrementándose también posterior a el mes de abril. Fíjense cómo se abre la curva de positivos y negativos, haciendo o teniendo una relación aproximadamente de casi la tercera parte de todos los estudios que se hacen están resultando positivos.
You can also look at how the curve and the graph starts to diverge, where originally there was about 9% people who were positive out of everybody who was tested. Currently, it's about 27% that are positive. And you can see that the curve is widening there.
El problema que hemos tenido en algunas oportunidades en la práctica es que en oportunidades hemos hecho el diagnóstico por la imagen tomográfica y no por la PCR. Hemos tenido pacientes que no nos da tiempo de tener el resultado de PCR, o el resultado de PCR da falsamente negativo, y cuando contrastamos las imágenes tomográficas de estos pacientes nos encontramos con esta situación. Es política nuestra que todo paciente que se le vaya a hacer un escáner que llegue por la urgencia, nosotros, un escáner abdominal, por ejemplo, nosotros completemos el tórax para descartar la probabilidad de positividad desde el punto de vista imagenológico.
So we've had issues where we've had negative PCRs and where they have positive CT scans. So it is our policy that everybody who comes in through the emergency is going to get abdominal CT, will get a chest or thoracic CT as confirmation, despite what the value of the PCR is.
Bien, como comentaban anteriormente, la distribución de los casos, obviamente ha ido en aumento, pero por mucho, por lejos, de lo que es el área metropolitana en comparación a las otras regiones. Yo inclusive luego quería preguntarle a Esteban por qué cree que la capital de Bolivia, La Paz, no es la que tiene más casos, sino creo que dijiste que era Santa Cruz. Un caso atípico, porque habitualmente las capitales de nuestros países en Latinoamérica son las que concentran la mayor cantidad de casos, y Chile así lo representa.
Yeah, so he wants to ask you a question, why in Bolivia the capital of the country does not have the highest number of cases, while in Chile and most of Latin or South America, it's usually the capital of the country. I'll go ahead and answer it right now. The phenomena is that Argentina is Buenos Aires, Chile is Santiago, Peru is Lima. But if you look at Brazil, the biggest populations are Sao Paulo and Rio, not the capital, Brasilia. That's kind of a different phenomena. In Bolivia, the biggest city was always La Paz. Over the last 30 years, because of economic development of Santa Cruz, that has shifted. And also, like I stated, the international airports there, and there's a lot of expats or foreigners who are working, or international companies in Santa Cruz, which is not that common in La Paz. There you tend to have the embassies. It's kind of the same phenomenon as what's occurring in Ecuador, where you have a higher incidence in Guayaquil than you have in the capital, Quito.
Ok, excelente. Esto es la comparación entonces de los casos confirmados de lo que sería Latinoamérica con, en este caso, Chile. Ahí vemos cómo Ecuador llega un momento que se pierden los datos, pero ahí está la distribución de los casos en Latinoamérica. Venezuela por fin aparece, milagrosamente, ¿ok? Y fíjense cómo aún, sin embargo, la relación de los países que hoy estamos conversando estaría Chile de primer lugar, luego Colombia y finalmente Bolivia.
So you can see how the growth of all this is occurring, and highlights that Venezuela shows up kind of late, Ecuador kind of dips and then comes back. But out of the countries that are speaking right now, Chile has the highest incidence, is creeping up to Peru and Brazil.
Bien, fíjense, ahora pasamos a la ocupación de las camas de la unidad de terapia intensiva. Igualmente ha sido un crecimiento exponencial a partir de mayo, la necesidad que hemos tenido de pacientes que requieren unidad de terapia intensiva. Fíjense cómo hace el crecimiento, y es cuando esto justifica los números de 1.200 camas de pacientes ventilados en la unidad de terapia intensiva. Y esta diapositiva que habla acerca de la distribución de los pacientes COVID, no COVID o por otra causa que han sido necesariamente admitidos en la unidad de terapia intensiva. Fíjense de la misma manera cómo la curva de los pacientes COVID está llegando a una ocupación que está por encima del 50% de las camas UCI en Chile.
So you can see that after May, the number of, or demand for ICU beds, and that was a previous curve, went up dramatically. And then you can also see the distribution where you had more availability of beds at the beginning of April and a very low number of COVID patients within the ICU. At this stage, it's 55% of the patients in ICU are COVID positive. Fortunately, they still have 13% beds available, and 30% is other pathologies.
¿Qué es lo que ha ocurrido? Inicialmente, las distribuciones de los espacios estaban en un área COVID y un área no COVID. Y eso ha ido incrementándose hasta tal punto de que se han convertido única y exclusivamente las terapias del hospital donde yo trabajo, el Sotero del Río, única y exclusivamente en un área COVID.
So what's happened is we used to have the ICU divided. So there was an area which was COVID and the other larger area which was not COVID. And at this stage in the hospital that he's working at, the entire ICU is basically a COVID ICU.
Las áreas de recuperación postquirúrgica también han sido divididas y fíjense cómo, por ejemplo, esta imagen del área COVID que está completamente llena, inclusive con pacientes en ventilación prona, en un área que poco a poco ha ido creciendo y abarcando casi todos los pacientes COVID. Todos esos pacientes que ven en esa fotografía son COVID.
So all these patients you're seeing here are all COVID patients, and what I understood was that this was actually the recovery. ¿Esta es recuperación, Pablo? No es terapia,
Sí,
¿no?
recuperación. No, no es terapia, es recuperación postquirúrgica.
Okay, so this, yeah, so this is your PACU unit or post-anesthesia care unit, and you can see that all these patients are COVID positive, and some of them are actually in a prone position in the recovery area. This is not their ICU.
Nos ha ocurrido que pacientes en sala, hemos tenido la necesidad de intubarlos en sala, pronarlos en sala y luego bajarlos al área quirúrgica porque es el único espacio disponible eventualmente y transformar un quirófano en un área de terapia intensiva para un paciente COVID que probablemente pase la noche y luego se redistribuya en el resto del hospital.
So we've had to actually take care of patients on the ward and actually intubate them on the ward, prone them, and then bring them down to the OR because that was the only place that we keep them overnight ventilated until we could go ahead and do an appropriate disposition of the patient.
A pesar de que nos hemos preparado, en nuestro hospital, además de eso, ha desplegado un hospital de campaña que inicialmente iba a desocupar pacientes de baja complejidad al hospital, pero que sin duda alguna yo creo que a futuro próximo todos van a ser necesariamente ocupados por pacientes COVID positivos.
So the hospital went ahead and did military-style hospitals up front, and the idea was that this was for the less acute or less critical patients. But Dr. Ottolino's feeling is that in the future, actually, that will also be occupied by COVID patients.
Y el comportamiento de la mortalidad, obviamente sabemos que esa mortalidad de 1,113 pacientes ha sido exponencialmente o ha crecido exponencialmente igual a partir del mes de mayo, con las relaciones que anteriormente comenté, 1.8 o 1%.
So you can see that mortality is dramatically increased in May, as you can see by the curve, but it still keeps the mortality rate of 1.8% in the patients, and then for the testing with 1%.
La comparación entre lo que serían los fallecidos a nivel mundial con Chile, vemos a Chile acá, cómo va aumentando y bueno, salvando las referencias mundiales de España, Italia, inclusive los Estados Unidos, pues todavía Chile se mantiene en una posición, aunque elevada, por debajo a lo que ha ocurrido a nivel mundial.
Yeah, you can see that Chile has been increasing in numbers there, but it's an elevated number, but it's still in the range of about Spain or Italy, less than other countries.
Y igualmente en comparación con los países de Latinoamérica. Ahí va Ecuador, Perú, que Ecuador tuvo una mejoría. Colombia, afortunadamente, un poco por debajo de Chile. Y allí se explican los 1,113 casos.
So you can see this is compared with the rest of the South American countries where Ecuador has had ups and downs. Brazil, unfortunately, and Peru have the higher number of cases, and Chile has been increasing and even above Colombia at this stage.
Rápidamente quiero decirles que ha pasado desde hace 100,000 casos atrás hasta ahora. Hemos hecho una redistribución de los espacios, redistribución de los equipos y hemos tomado medidas de prevención.
So I want to say what's happened in the last 8 weeks, over 100,000 cases. So there's been a redistribution of the spaces, of the equipment, and also of the PPEs.
Estos son una serie de láminas donde obviamente tenemos pabellones exclusivos para COVID, con todas las características propias de los manejos. Tenemos un túnel de sanitización que utilizamos luego de entrar a este tipo de pacientes. Y como la parte erótica del COVID es que tenemos que tener muy bien el protocolo, más bien de retiro de las EPP que de la colocación de las mismas.
So these are some of the changes we've had. We're actually using sanitation tunnels, and I guess we'll talk about that later, since I don't believe in them. But he also argues that the most dangerous part is actually the doffing or removal of PPEs, and it's not the donning or putting on of the PPEs.
Yes. El quirófano, obviamente preparado con todas las regulaciones, menos cantidad de personas, todo cubierto. Y lo más importante es la redistribución del personal, que esto es muy importante. El equipo quirúrgico se divide entre expuestos y no expuestos y se hace una rotación cada 14 días para disminuir la exposición del equipo en el hospital.
So they've redistributed the physicians. They try to limit the number of people who are actually in the operating room. And they also determine here, you see 2 figures not exposed, and then 3 who are exposed. And after 14 days, they rotate them around to try to limit the amount of people who may potentially get infected.
A pesar de ello, hemos tenido 55 médicos que han sido contagiados. Hace 2 días murió un paciente, un gastroenterólogo, y un total, hasta la fecha tenemos 77 ventilados en el hospital donde yo trabajo, en el hospital Sotero del Río. Hemos tenido bajas completas de equipos quirúrgicos que han resultado positivos luego de testearlo.
So we've had 55 personnel physicians who have been COVID positive. Yesterday, a gastroenterologist unfortunately passed away with this, and they've had entire teams that have been turned out to be COVID positive.
Bien, se han tomado todas las medidas, se han utilizado pues los protocolos adecuados, y esto lo voy a pasar muy rápido. Las condiciones de trabajo son muy duras, casi no te escuchas, sin duda alguna hay afecciones faciales, auditivas, dolor que produce tener esa máscara, y obviamente las medidas generales de los espacios del hospital que han sido muy rigurosas, desde los lugares de convivencia hasta los lugares de tránsito común.
So working under these conditions has been rather difficult. You can see the straps from the PPE. It causes a lot of pressure. You can barely hear each other. But the hospital's made a good recourse of trying to isolate and identify the areas and provide protection for the personnel.
Para finalizar, ¿qué es lo que al final hemos hecho? Una restricción de las cirugías electivas, obviamente. La cirugía de urgencia con el mínimo personal y más capacitados. El manejo conservador en la medida de lo posible, de casos que obviamente puedan manejarse de forma conservadora, y obviamente derivar a otros centros de cirugía de menor complejidad, y lo que obviamente ha disminuido es la protección individual y social.
So we've restricted all elective surgeries. Also, any emergency cases are done with the minimal personnel, and also the personnel with the highest capacity or better trained for the job, if you will, so no residents and just staff. We try to do conservative management within whenever it's feasible, and we also derive patients for other surgical centers when they're of less complexity, and also all the measurements for individual protection.
Muchísimas gracias.
Thank you very much.
Thank you very much, Dr. Ottolino. Gracias, Dr. Ottolino. Let's go straight to the pool questions. Let's answer the question very quickly. Valeria, please launch the questions. Then just after that, the question I'm going to go straight to Dr. Raul Coimbra. So, okay, first question about social distancing in your area. So what's happening there? Please click and go to the next one. Second question, question about lockdown. If your area, your city had lockdown and if it's what's happening right now. Question number 3 about the positive case in your area, your city, is decreasing, increasing, stable. Question number 4, if you have any protocol to treat the positive COVID patients, or any physician can treat any way they want. Question number 5, if physicians, nurses are using N95 masks to treat the patients in trauma bay and emergency room. Question number 6, medications that you're giving your city, your country, you're giving to the patients that are positive, they have a positive test, are going home. So some people said some that having prophylaxis, etc. So let me know, patients that are positive but are going home. So what kind of medication are they receiving? Next question, patients that are positive need to be admitted to the hospital, not to the ICU, but the floor, to the hospital. What kind of medications are they receiving? Okay, and then next question, patients that need to go to intensive care unit, what kind of medication are they receiving in the intensive care unit? Another question, what kind of medication do you think that is making the patient improve? What kind of medication you're giving to your patient, you believe that they're improving, making them improve? And last question, what kind of medication are giving to your patient you don't think they make them improve? Okay. Are giving or using the past and you don't think they make the patient improve? Okay, after clicking answer all the questions, please click submit. Okay, while you finish your pool of questions, answer all the questions, click submit. I'd like to ask Dr. Raul Coimbra to quickly comment on the answers. And then Dr. Coimbra, I have a big question for you. You have been in this meeting since the first one, 3 months ago. You saw what was happening in Europe. Then you saw the pandemic, the coming to the United States, not to your state, to your county. You participate in the response to your county. And now we are reopening and we see the peak going to the South America right now. What kind of advice, recommendation can you give to our friends in South America? You have been in most of these countries, have been traveling around the world. So what can you tell from the experience that you had in your area? What kind of advice can you give to our friends in South America, Latin America, please? So Valerio can finish the pool and then Dr. Coimbra going to comment.
Thank you, Antonio. Yeah, it's hard to compare places and responses because every place is different. I would say that solutions are also local, and what works in some places don't work for other places. We saw today 3 presentations with 3 different realities in the same continent. So even South America is not only one place, and we know that different medical systems lead to different responses during mass casualty disasters and pandemics. I think what's important is for surgeons, which it's the majority of the attendees of this webinars, to realize that we need to lead in hospital preparation, regardless if this is a medical disease or a surgical disease or an earthquake or major wildfires, whatever the situation is. Surgeons have a responsibility to lead hospital preparation to mass casualty or pandemics. And I think And the reason is because surgery is directly affected by those situations. For instance, most of us, if not all of us, at some point in our locations have to stop elective surgery. And that has a tremendous impact in society, has a tremendous impact in hospital revenue, has a tremendous impact in patient outcomes. People have had cancer operations delayed for 3 months, and this may be a big deal for them in the future. So we need to be in the forefront of those preparations. What I would say, since I've been through the beginning, through the peak, and now we are very going over the other side of the curve and have very low volumes of COVID in our hospital, in our county, I would say one thing: this disease is not going to go away. So all we heard today about acute preparation is great. Most countries that present today, they're still going up. But be aware that this is not going to disappear. And we need to be part of the leadership group that will help our hospitals to be redesigned. We are going to have to live with this disease. So we are going to have 2 hospitals within a hospital. We are going to have the COVID piece and the non-COVID piece, because our responsibility is not only for COVID patients, but our responsibility is to society. And we still need to continue providing care for trauma, for burns, for emergency general surgery, for cancer, for cardiovascular disease, it's stroke, etc. So we need to be smart to redesign our hospitals, change flow, cohort areas, to learn that we are going to have 2 realities within a hospital and how we are going to do that moving forward. And the other thing for surgeons is, okay, this is going to decrease one day. It's not going to go away, but it will decrease to the point that you need to reopen. And how do you reopen? And I think that's very important.
Thank you, Dr. Coimbra. I have a question for the panelists in Rio, but let's just check the answers first for the pool. Again, most of the places they have social distance, but not all the places have everybody respect social distance. Lockdowns, almost 50% had lockdowns, but not all but only 16% saying that people respect the lockdowns. 45% of the case or the place said that the number of positive cases are still increasing, and 25 is slightly increasing. So you can see then afterwards, I'm going to analyze the data by country. You can see in South America, it's still going up number of cases. In Europe and in North America are going down. Protocols, most of the places have protocols, 86%. Most of places will have people using N95 masks, and it is very important. And still, there's a lot of controversy about what kind of medication are given to your patients. So there's a high number of people still receiving hydroxychloroquine and azithromycin, even if they don't need to be in the hospital. And we can discuss this afterwards also. In hospital, still prone position has been effective. the VT prophylaxis has been almost 60% of the patients receiving, and hydroxychloroquine and azithromycin is still a high percent of the patients receiving that in the hospital. In the critical care unit, then prone position is huge. DVT prophylaxis is still almost 50%, and anticoagulation goes up with other medications. Medication, you think, improve the patient. Again, procedures, prone position is the number 1, 61%. DVT prophylaxis and full anticoagulation just falling. And medication, I don't think they improve the patient. Hydroxychloroquine and azithromycin are the leading one. I'm going to go straight to our friends in Rio de Janeiro. Dr. Lima presented some data from last week regarding his hospital. And then afterward, Dr. Bruno going to talk representing his bite. In Rio de Janeiro, Dr. Lima, the state saying that people should still stay home, but the mayor, the city of Rio de Janeiro is reopening, and you know that still Rio de Janeiro is still at the peak or going to the peak. So what's really happening, and how do you see the situation in Rio de Janeiro in the next few days and weeks? Dr. Lima, please. Dr. Lima, are you there?
I think we lost him, Dr. Martos.
Lost him? Okay, Dr. Bruno Pereira.
Go ahead, Dr. Bruno.
Dr. Bruno?
All right, my mic was on mute, I'm sorry.
Okay.
Yeah, here in Brazil, the situation is critical. We are actually climbing the ramp. I have a graphic to show you guys, so I'm trying to figure out how I will do it, just to show you some numbers. So here we are, and here it goes. All right, so I am expecting you are seeing this graphic. Is that true?
Right.
All right, so here we have the data that we are actually in Brazil to since the first day of June. So we have a number of deaths of 30,000 people, and here this is a little bit more. I have a actual number of 555,000 people accommodated with the COVID disease. And to answer your question, Antonio, in Rio, we have these 54,000 number of cases and almost 5,500 deaths. In São Paulo, the scenario is a little bit worse. We have more than 100,000 cases and 7,000 deaths. It's a lot. Actually, I am in Campinas. So in Campinas, we have a stationary situation, but we have an occupation of 80% of the ICUs with COVID. Some hospitals are actually closing doors for other cases because they can't support other patients other than COVID patients. It's important to call your attention also for the northeast zone of the country. Here is the northeast zone, and the number of cases are kind of going sky high in this geography of the country. So Brazil is a very big country, as you can see, and we expected to have a lot of people committed with the COVID disease, but not like this. And we are actually trying to control this scenario. Some places, like in the central zone of the country, Mato Grosso, for example, here in the top, in the bottom of the scale here, they have not many cases yet. We are feeling that the time of the disease is actually different because the country is so big that São Paulo is leading the cases, and the northeast part of the country is leading the cases, but there are a lot of states that are in a different time of the disease. So this might be a problem also. So that's it. The numbers can tell by itself. So it's critical. For this point, it's critical, Antonio.
Thank you, Dr. Pereira. Dr. Lima, I don't know if you are back here. So we had time, Brazil had time to prepare. So what didn't work in the preparation for Brazil? And in Rio de Janeiro, for example.
What did work, you asked me?
What worked and what did not work?
We believe that, thanks for the invitation, Martos. Bruno talked a little about Rio scenario, but what I believe it's worse a lot, first, is we have a good, strong emergency service who receives the patient and makes a triage, then who is the patient who have to stay in the hospital and who can go home. After all, we have Dr. Coimbra talked about structures in the hospital. We have units to receive the step-down patients like that in ICU. And we believe that transfer these patients is to ventilate patients in a good manner. We have a good experience in non-invasive ventilation of these patients, and when necessary, they go to the ICU and to ventilator, and to have used different approach for this patient. Sometimes recruiting someone, sometimes we have to prona, sometimes we have to give nitric oxide, and sometimes, and final station could be ECMO, but we don't do that, excluding one patient. And we don't believe, we have some extreme patients that corticoids is an idea that's arriving now. We are believing that you can use it more preventively, more early, perhaps for the anti-inflammatory phase of that. But we do not believe in another. We do not believe in other medications. Now we are beginning our experience with the convalescent plasma. It's still early, but we are part of a great group. Perhaps the group was going to get an experience to see if it could be good or not. But if I have to say to you what's important for the patient, you have a good triage to see if the patient has to stay in the hospital or not, and to ventilate this patient with attention, with many skills, with many other kinds of ventilations. For me, that's what makes the difference for these patients. Thank you.
Thank you, Dr. Lima. Thank you very much. Thank you. Dr. Neira, Argentina has borders to Brazil, and the situation in Argentina is different. So how was the planning? How did you execute the prevention? So how did you manage the COVID surge in Argentina?
Thank you, Antonio. I would like to say first that I am very honored and I'm pleased to have been invited here in the Pan-American activities. It's a bit different because we have now about 16,000 patients, COVID positive patients at the June the 1st, and 540 death people. We started lockdown in March 20th. March the 20th. We have 70 days on lockdown, and probably this lockdown will be extended for the next 15 days at least. We started to increase the amount of cases 1 week ago, especially in the surroundings of the city. The city of Buenos Aires, I'm going to show you next Wednesday, but the city of Buenos Aires has 3 million people, but the surroundings of the city, the metropolitan area, has 9 million more. The entire metropolitan area is 12 million people, and the problem is in poor settlement neighborhoods. We have a lot of slums in the surroundings of the city, especially in the province of Buenos Aires that surrounds the city, and some slums in the city is about 100,000 people in poor settlements, and this is the problem. The problem is in this, especially in these cases, we are increased the last week. We are now in about duplication rate. Our duplication rate is about 10 days in the city, and for instance, in the entire country is about 30 or 37, because there are provinces that don't have any case of COVID. We start also the close of boundaries was immediately the national government took the leadership of this disease, and the idea to flatten the curve was to give the health system to be prepared for this increase of cases. I'd like to congratulate our colleagues for the presentation. I'd like to ask Pablo, which is the reason that the Chile's mortality or Chile's lethality is so low? Is there any explanation? And the other question I have to Pablo is, which is the reason of the dramatic increase of the cases in the last weeks?
And I'm gonna go to Pablo. Pablo, I'm going to go to you and to Esteban. Maybe Esteban going to translate also. So, and came to my attention also the mortality at for the ventilated patient in Bolivia is low compared to what we had in Italy in beginning, etc., etc. So are you seeing, are you learning how to treat the critical patients? So that's the same question to Pablo and to Esteban. So did you learn during the last 3 months how to treat this patient? And then after the 2, Dr. Coimbra can comment on that also. Why the mortality in the critical patients are decreasing throughout the months? So Dr. Ottolino, please.
Yo, volviendo un poco a lo que comentaba Jorge, pienso que la disminución de la tasa de mortalidad está relacionada con, un mayor número de estudios que se están realizando, y obviamente al tú tener mayor número de estudios, obviamente eso te va a disminuir la tasa de mortalidad. Por otro lado, las políticas propiamente de salud que se están implementando con la inmediata encapsulación de todos estos pacientes, tanto positivos que requieren tratamiento intensivo, como aquellos pacientes positivos que requieren solamente aislamiento. Y la otra pregunta, en cuanto a el aumento que habías comentado, el aumento exponencial de la cantidad de casos, yo creo que ese mes fue un poco que el gobierno flexibilizó un poco las medidas de contención social y eso disparó los casos clínicos. Es decir, hubo un momento en que la quarantine fue disminuyendo hasta que cuando le hicieron otra vez total, fue que entonces creemos que la curva vaya a empezar a bajar, pero la atribución fue un tema de la cuarentena.
Okay, so Pablo is mentioning there quickly in English that he thinks that the numbers and the mortality is so low because they've done so many testing in Chile, and that's impacted the overall mortality. As far as the why was there a big peak in May? Because you relaxed the social distancing laws and allowed people to curtail some of those social distancing measures. And that's what led to a second peak, which was more significant. As far as what has happened in Bolivia, I can speak only for my institution where I work. I think that we were blessed, if you will, to have our general manager is an infectious disease doctor, and Rodolfo Quiroz, Dr. Neira knows him very well.
Yes.
And Rodolfo, very early on, made it a team effort. He realized the importance of this disease. He started getting all the different partners involved, and there was extensive review of the literature. We learned from what had happened in other countries. And so one of the things that's been kind of controversial, and you'll see every time I put down lopinavir, ritonavir as an option, we do that for our patients who are admitted to the hospital if they're considered to be high risk. All patients in the ICU get lopinavir, ritonavir. There's been some question about it. There's a study that came out in New England Journal of Medicine. The lead author was Cow. I believe that was in April. But the study was underpowered. If you look back at the SARS epidemic, there's a 7% decrease in mortality, 22 to 15%, the uses of this antiviral. We were not really enthusiastic with hydroxychloroquine or azithromycin. Actually never gave azithromycin. First 2 patients in our unit developed arrhythmias from this. Other thing is that we did have, both of them developed secondary pneumonia. So since then, they've been doing decontamination paste in the mouth and through the GI tract, and that's actually helped quite a bit. We tend to prone the patients early. We tend to vent the patients early. We've seen, we've been able to hold a couple, especially young patients, without venting them and just supplemental oxygen. We do have negative pressure rooms, so kind of controversial using non-invasive ventilation in those patients, and they've been able to be observed and then be able to wean off that. Or patients that we extubate, we've moved over to non-invasive ventilation for the same reason. We found that patients that we've delayed intubation, some of them start to develop fibrosis, and then venting them has been rather difficult, and they tend to stay on the vent much longer. Overall, we've been very pleased. I've had 3 colleagues in the ICU, 2 of them on the vent, 1 not on the vent. Last one got extubated yesterday. One's at home and the other one's on the ward ready to go home. The first patient we received, elderly gentleman, close to 70, obese, 2-pack, smoking history, coronary artery disease. I thought for sure he was not going to make it out of the unit. At 3 weeks, we decided to trach him because he had neuropathy of critical illness, and that was very controversial. Even Dan Poos called me and said I was nuts. Okay, I love Dan and thank you, but we did take measurements. I actually did the case, the trach open in his room, and the patient is home currently. So we've been very successful. I think it's because of the team effort and working a multidisciplinary team and having good leadership with Dr. Quiroz, who's a ID guy.
What about Dr. Coimbra? Dr. Coimbra, what do you think that's working? What changed in the management of this patient from March to now?
I agree with Esteban's assessment. I think you know, you need to be aggressive, putting these people in the ICU early on. We used a lot of non-invasive ventilation, vapotherm and BiPAPs, because of the negative pressure rooms allows us to keep the virus enclosed in that space. So the issue of aerosolization is not too significant. But obviously those that need to go on mechanical ventilation should go early. Proning in the ICU when you sedate those patients is obviously part of our routine protocol. We use a lot of proning outside of COVID as well in the surgical ICU. We believe in proning. And for patients that are not intubated, we are asking them to self-prone. And some patients are compliant and they do a pretty good job. I want to make a comment because, you know, we look at all these numbers from different countries and we try to compare them, and we should not. The numbers are related, so mortality, positivity rate, etc. They are dependent on how aggressive your testing is in your country. So look at Brazil, for instance. Brazil has 500,000 cases and has 200 and some million people. The United States has 320 million people and has 1.5 million cases. So there is some problem there, right? One is probably testing more than the other. Neither are testing enough, because we should have 3 million cases for our population and Brazil should have 1.5 million cases. So those cases are out there. And if a region has low number of cases, it just means that we are not testing enough there, because the prevalence of the disease should be similar. Now, there are differences in the virus, though, and the virus is mutating. So the disease in northern Italy was different than disease in China. And what we are seeing in California is much less invasive and lethal than what people saw in New York. So this is a very tricky disease, and we need to be very careful when we look at those numbers, not to compare apples to oranges, because the comparisons are not fair.
Thank you, Dr. Coimbra. We're running out of time. I'm going to ask a quick question to Dr. Peralta, then Dr. Von Salomea. Dr. Peralta, we're gonna have COVID for a long time. So how are you preparing your hospital to have COVID and regular patients at the same time, like Dr. Coimbra said before? So any special preparation for the post-acute phase?
Great. Thank you for the opportunity, and thank you for the panelists and the speaker, especially our president, Felipe Vega and Esteban, and the other ones. So we just have an interview with one of our graduated fellows, and we have dedicated hospitals. He come in a hospital dedicated with over 300 ICU beds just for COVID. It's incredible. I'm so proud of him. He just took up around 30 patients. There are 20 units, ICU units in the whole hospital, over 300 beds. And it's like you mentioned, prong is really the issue for them. Every treatment is under a protocol here. But I think what we have done it for the reopening is that the government has taken the contact tracing as a mandatory tool now for everybody. If I go to the supermarket that I went today after my call, I have to show my contact tracing card, and I have to open my application, and then after that they can let me go in beside the temperature. So this is my application. And then if you may see, I'm green. If I'm green, I can go and enter the supermarket. I can enter the pharmacy, and so forth. So if the color change to another color when I'm passing by the dedicated COVID area in our hospital, the ED, it's an alarm. So you really have to, contact tracing really help us to, to keep beside the mandatory masking and all the hygienic things. But I think it's a long disease. We are really opening, even including the Dominican Republic is doing phase 2 of the opening now. It's really difficult to control in our countries like Bolivia. Like Esteban mentioned, we have a significant percentage of informal workers to control the population. So everybody trying to do the keep distancing. But I think this contact tracing, I know it's an issue that we even, it's an issue with privacy, but I think for the benefit of the country, now the new tools, I think from by Apple and MIT, they have an application with Bluetooth that they don't describe, they don't show you name, they only show the people that they are, close to you. Contact tracing, I think, is probably going to be one of the best tools that we're going to do that. We're going to change. Everything is going to be webinar. Most of the university, a lot of university will disappear because, a lot of the Chinese, influx that we're going to have in the education is not going to come to Australia, it's not going to come to the US. So we're going to be hurt for a little while. For us, the three main things in the Dominican Republic is tourism, is going to be, the diaspora. A lot of Dominican living in Europe and the United States, this money is not going to be there for the economy. And so forth. It's happening to many other countries. Dr. Martos, I'd like to thank you and I congratulate you, but I would like to see if you can invite somebody from Costa Rica that is being a great country to just observe how have they done there with 1,000 cases and only 10 deaths. I think that will be great. I follow most of the countries in Latin America, but I think this is great. And I even though we should not compare the numbers, there are some numbers that we should compare. For example, the testing positivity of the testing from country to country, because I think, and also the impact of the disease, because I think in the Caribbean and the Dominican Republic, we only have 1.7% utilization of ICU in those patients. So, I think the beautiful weather in Merengue, I don't think the disease really impacts us as much as has impacted in other countries. And this is something that I probably will have to study. Thank you for the opportunity.
Thank you, Dr. Peralta. You are already above time. So I'm going to go to Dr. Juan Carlos Salamea. So Dr. Coimbra mentioned something. The disease is going to be here, but California, Miami, United States went to social distance. Some places had lockdown in the globe, but the economy was hurt. The economy was bad. But what can you do, like in place in Brazil or in Ecuador, in many countries in South America, where if there's no, the people don't have food if they go to work. The informal workers, if they don't go to sell something during the day, they don't have food to eat at night. So, Dr. Salamea, you spoke last month about the situation in Ecuador. So, what should be done, or how can we deal with these poor people, this poor area, to prevent the spread of the disease?
Hi, everyone. Thanks for the opportunity. I am totally agree with Dr. Coimbra. We have to learn how to live and work with this virus. In Ecuador, you see the numbers and the deaths and the cases. I think the problem was the first case was the earliest than the other countries. Now is interesting because the curve is still high, but the government decide to leave the people. The most states in our country now is almost normal. Now is in the, every person have to take care of him and their families, no? And I think maybe this is the way. Maybe this is the way. The problem is with the hospitals. It's very hard to have two kinds of hospitals in the same hospital. For us, the most of the more problem is the number of physicians, nurses, and all of the facilities. Pablo Ottolino explained about the use UICs and the spaces, and in Ecuador it's the same. The more beds and intensive care are with COVID patients, and we are stopping all of the elective patients, and the problem is with the cancer, with the oncology patients. I don't know what we can do with this, and also the government decided to open and leave the people to the cities because a lot of pressure with the poor people, and the people need to work. The most of the people in Ecuador need money day by day and money for eat every day. For I think only less than 10% can stay in home. The 90% need to go to the streets to work. It's difficult. One comment. In Cuenca, we live at 2,500 meters over the sea. We have a critical cases, but it's different than Guayaquil and the other cities in the Latin America. Maybe the altitudes have a little influence with this virus. I don't know. And now, in Ecuador, Quito, Guayaquil, Cuenca have the same cases. The curve are the same, but the people are learning how to live, how to work, and take care of themselves.
Thank you very much, Dr. Salamea. Next week, Dr. Neira is going to be presenting, and for sure, you're going to have a lot of comments from here as intensivist also.
Thank
Dr.
you.
Neira, thank you very much.
May I propose you something,
Sure.
Antonio? Could you add in the questionnaire you have convalescent plasma, because I think it's important and will be useful to how they work
Sure.
in our countries.
Sure. Thank you. We're going to have this next week. So I'm going to go to the final comments from Dr. Felipe Vega, President of the Panamerican Trauma Society, Osvaldo Coimbra for World Coalition for Trauma Care. Dr. Vega, your final comments, please.
Yes, I heard a comment about the governments are measured the occupy with ventilators and beds, but I hear Esteban talking about it's not a ventilator only, it's all the logistic and people and nurses and physicians who is involved in all the treatment. So I think we have to capture some more comments about that and write something about that, because it's a reality. We don't have enough people to attend the patients, and it's the new way that Dr. Coimbra comment that we have to change our mind and to live with this, with another form of treatment and another form of organization, and that's why it's all my comments.
Thank you. Dr. Coimbra is going to send us 2 papers that he wrote to his group about the COVID-19. And then they're going to distribute this to the panelists, and they're going to have these papers available maybe at the website of the Panamerican Trauma Society for anybody from this list. They want you to check his work and his publications on this area. Dr. Coimbra, your final comments, please.
Yeah, again, thank you so much, Antonio, for putting this together. This has been a terrific opportunity, not just to see our friends in this new way of connecting. We are huggers in South America, right? So we can't hug anymore. So at least we can see each other through the screen. But I think the content was excellent. And I think what we need to think about from this type of webinar that you spearheaded is that there are perhaps some great experiences that we could share offline, and perhaps put together a manuscript of lessons learned, things that we developed for how we train non-ICU people to provide ICU care. We wrote a complete protocol about this that I can share. And I'm sure Esteban has done stuff in his hospital that could be used by Juan Carlos in Ecuador, and Jorge, as an experienced intensivist, has done a lot of things in Argentina that could be useful for Ricardo in Rio. and we cannot miss those opportunities. You know, we wrote 2 or 3 papers during COVID just because we were motivated to put out some stuff that people could use based on our experiences. And I think the experience of this group is very rich, so we should do it.
Thank you very much, Dr. Coimbra. Let's make it happen. Okay, in the name of the Panamerican Trauma Society, the American Association for Surgical Trauma, International Relations Committee, World Coalition of Trauma Care, University of Miami, and Virginia Commonwealth University, VCU. I'd like to thank everybody that joined this conference today. Special thanks to all the panelists and presenters. And looking forward to see everybody next week. Please stay safe and have a good week. Thank you very much.
Thank you very much.
Thank you. Bye-bye.